you who don't recognize me, my name is Erik Kreil. I'm a student physical therapist from Lynchburg College. And today I'll be presenting on the importance of upper extremity differential diagnosis. The purpose of this case study, is to discuss the relevant upper extremity pathology that you may see and some conflicting findings. And then we're going to discuss some potential alternative hypotheses with these conflicting findings and a correlating treatment approach. So just a quick note, as I go through, we're going to discuss an initial examination of the involved upper extremity with some distal symptoms, and then we're going to get into an examination more proximally. So you'll probably be suspecting some things as we go through. Hold your questions. So the patient that I received was a 58-year-old male. He was a computer engineer manager and a recreational hunter. And the prescription that we got from the PCP said, eval and treat right biceps tendonitis and right carpal tunnel. His primary concern was anterior shoulder pain, limiting his hunting and reaching overhead. The hunting was limited due to the barrel pressure on his shoulder. And then he had hand paresthesia and pain that woke him at night and made sustained computer work more difficult. So he really couldn't do work over 2.5 hours, and his work required him to work 8 to 9 hours on the computer. These symptoms were concurrent, and they began about 3 months ago with insidious onset. His NPRS for both ranged between 4 and 6, which is pretty moderate, but the way that he described it, it was more something that just bugged him. So he really made it seem like it was just in his life and sort of low in the severity scale. He said these were constant, but they were worsening. His other concerns was the perception of right-sided hand weakness, which was new and relative to these onset of symptoms. His symptoms were better with ibuprofen, heat, and a guarded upper extremity position. And he had self-initiated wearing a carpal tunnel brace at work, which he wasn't really sure if it provided much relief, but he liked wearing it. He does have diabetes too. And this clinic's normal outcome measure for folks with arm symptoms was the upper extremity functional index. And for this, 80 out of 80 is the best that you could get. So the MCD for this functional outcome measure is 9 points. So he had already ceilinged out at 73. So realistically, I should have given him a different outcome measure from the get-go, but that's something that I discussed in my limitations. And it's just worth noting that his symptoms are right-sided and he's also right-handed. So looking at his SINs, I just use this to sort of gauge the vigor of my examination. He described his severity as low, the irritability was low. The nature of his symptom was something that was throbbing, something that just bugged him. And then research suggests that it's also important to look at the nature of the patient, because this is going to come into play a little bit later, where he, right off the bat, is a personality that just wants to attack the problem and get rid of it before it becomes anything worse. The stage was chronic and it's worsening. So when we observe him sitting on the plinth, we can already see that he's sitting with a slight right cervical side bend towards the affected side. And then it just sort of looks like his right upper quarter was elevated relative to his left. So what I did was I went behind him and placed my thumbs on the inferior angles of his scapulas. And you can see a relatively elevated scapula on the right by about a thumb's width. His active range of motion at his glenohumeral joint, elbow, and wrist were all functional or normal and equal both sides. But he had familiar onset of symptoms above 90 degrees for any GH motion on the right. So that's flexion, scaption, or abduction. And his strength was also relatively unremarkable. He was very strong for every muscle test that we did. His handheld dynamometer grip was within the normal range for his age group with right-sided dominance. Although glenohumeral resisted internal-external rotation did mildly reproduce some of his familiar symptoms. And I wanted to test his mid to low trap muscle test, but since that would require his arms to be above 90 degrees, he deferred it for this initial visit. I conducted a brief neurovascular screen, which was largely unremarkable. His sensation was grossly intact to light touch. Myotones were equal both sides, and I checked his distal radial pulse, which was also equal both sides. My palpation exam was also largely unremarkable through the soft tissue. He did have point tenderness along the right biceps long head tendon, but otherwise pretty unremarkable for recreation of his pain. Special tests were also largely unremarkable. I conducted the Jurgensen's test, the Phelan's test, and manual transverse carpal ligament compression with wrist flexion, which were all unremarkable. His Tinel's test was positive at the right cubital tunnel though. So our patient ICF model, in sum, so far, is a 58-year-old male, sits on the computer 8 to 9 hours of the workday. He likes to hunt, but he has shoulder pain that he experiences above 90 degrees, and then hand paresthesia and pain that wakes at night and makes typing on the computer more difficult. Questions so far? Okay, so next what we're going to do is we're going to run through the suggested pathology from the PCP script, and we're going to discuss where it may land on our Google hit list based on our patient presentation. So with biceps tendonitis, the biceps roll at the elbow for elbow flexion, pronation, supination is pretty well established, but the long head biceps tendon roll at the shoulder is more controversial just due to unclear experimental findings. So it can be difficult to look for a particular mechanism of injury if they don't fall within some of these at-risk populations. So folks that you would expect to see this with would be someone with a corresponding impingement or rotator cuff pathology. They're more likely to be over 60 years old. And then also folks who have repetitive motions like with overhead athletes, just due to the mechanism of glenohumeral adduction, internal rotation, and forward flexion, which our patient is not. So what you would expect to see in your exam room is the subjective report of generalized pain over the bicipital groove. Objectively, you would see palpation exam revealing point tenderness over the bicipital groove. You may see decreased glenohumeral internal rotation. You may have reduced strength due to rotator cuff involvement. And special tests, you would just test for the same things that we just talked about, impingement, rotator cuff, or biceps pathology type things. But what we see is a little inconsistent and pretty convoluted. The subjective report is there, the palpation finding is there, but he doesn't have reduced motion, strength is fine, and Jurgensen's was negative. It's worth noting that Jurgensen's does have pretty good specificity, but its sensitivity is pretty poor. So even if you get a negative Jurgensen's, you can't necessarily rule it out. His past medical history, he's also not really within the at-risk population that you would expect to see this with. But overall, as you can see, I didn't really test for rotator cuff or impingement, so I should have been more comprehensive with this exam. With carpal tunnel, we know that this is the involvement of the median nerve as it runs between the concave carpals and the transverse carpal ligament. And what's going to happen is constriction can lead to an hourglass compression along the nerve. Chronic constriction can lead to fibrotic degeneration, leading to loss of extensibility. It's said to be the highest prevalence of all forms of compression neuropathy. So pathologic diagnosis can be difficult due to argued validity of these tests. So really what you're going to look for is the at-risk population, and one thing I'm going to talk about next. So at-risk population is going to be anyone that would have an extrinsic or intrinsic factor that would either influence the volume around the nerve or the volume of the nerve within the space. So an extrinsic factor like obesity would influence the volume of the space around the nerve, whereas diabetes might influence the nerve within the space. The best evaluation practice, according to research, would just be a relevant subjective history. So, do their symptoms, their paresthesias, their pains mimic median nerve involvement? And though our patient's symptom diagram was pretty general, he just drew a circle around the right wrist. With further subjective questioning, it did resemble a median nerve pattern in the hand. So what you'll expect to see can vary based on the grade of the damage. So neuropraxia, which is demyelination to the nerve, you may get a positive provocation test that replicates compression, so like Phelan's. You might also have abnormal light touch and vibration. Grade 2 would be axonotmesis. This is damage to the nerve, the axon itself. And so here you would get a positive provocation test for regenerating nerves, so like positive Tinel's. You might also get abnormal 2-point discrimination or asymmetric strength. And then grade 3 would be a combination of both. Here you would see visible thenar atrophy, and the symptoms would be described as constant. But what we see again is a little back and forth. Balen's was negative, grossly intact to light touch, so that's negative. Tinel's, though, was positive. His strength was fine. There was no observed atrophy, but he did say that his symptoms were constant. The special tests, we'll talk about these in a minute. And again, I should have been more comprehensive in my neurologic testing, but there was no observed thenar atrophy. It's worth noting, though, that he does have diabetes, which is the at-risk population, and his subjective description does fall along the median involvement. So with the special test, he got 2 out of the 4 that I tested, but these weren't necessarily the highest or the best, the most sensitive or the most specific. Compression with risk flexion was the best for both, which was negative, and Balen's was also negative. So we're really not getting a great picture of, is this a road that we want to go down right now? So, the goal of our examination at this point is to find data based on our patient concerns and draw connections that make sense. And we are sort of feeling like we're finding smoke, we're able to get some positive tests, but we're not really recreating his pain all that much where you can definitely say that's it. So we're not really finding the fire. So what we need to do is refer back to our Google hit list and determine where do these things fall? How likely is it that this patient has really some true involvement at the shoulder or some true involvement at the wrist? The next part, I'm going to discuss the second half of my initial evaluation as we check more proximally. So an alternative hypothesis would be looking more proximally at the neck. And what we find here is with a cervical motion, besides flexion, all other motions are grossly restricted by 50%. And extension actually reproduces his familiar symptoms definitively. Upper limb tension tests, ulnar was positive and radial were also positive, but these were at end range, and that was the same for right and left. Median nerve, though, was positive with reproduction of his symptoms, lacking the last 60 degrees of elbow extension, and this is reinforced with cervical side bending. And so the 60 degrees that he lacked on the right was 20 degrees different than the 40 that he lacked on the left. Sperling's was positive on both sides, and he had significant reduction of both his anterior shoulder symptoms and his wrist symptoms with manual cervical traction. And so when we think back to what we observed before even speaking to him, we see that right cervical side bend and that right upper quarter elevation. That could be an effort to slacken the nerve if it's truly tense or irritated. So now we're feeling like we're getting somewhere. We're able to really recreate his symptoms. He's able to say, that's my pain, and we're beginning to link it closer to function. So there's a pretty well-established CPR for proximal involvement. This describes upper limb tension test that recreates their symptoms, left versus right difference of over 10 degrees of elbow extension, which we have, and symptoms that change with neck position, which we have. Cervical distraction does reduce the symptoms, Sperling reproduces the symptoms, and with gross 50% restriction of neck motion, he has less than 60 degrees of C-spine rotation, though it would have been better to measure objectively. There's a pretty good case study that looked at folks who met the CPR for cervical radiculopathy. These folks had an NPRS average of 4.66, which is almost exactly what our patient had, between 4 and 6. They used the PSFS, and for these folks, C-spine extension and upper limb tension test reproduced their pain, which is similar to my patient. Their manual treatment was cervical thoracic junction thrusts and soft tissue massage to distal structures. And they did exercises like chin tucks, scapular retractions, pec stretching, and nerve slides. After a period of treatments, these folks reduced their NPRS scores to 0 out of 10 and increased their PSFSs to 10 out of 10. Another JOSPT article discussed the relationship between folks with neck and arm pain. They looked at folks with distal paresthesias, feelings of weakness, which our patient had, and clumsiness, which was his word. And they had significant symptom relief with manual traction, which was also true for our patient. They looked at 86 folks who had signs like this, and they split them up into just exercises alone, like the ones that we just mentioned, and exercises plus cervical traction. And whereas after 4 weeks, both groups had significant improvements, the group with the exercises plus the traction had significant improvements beyond 6 months and a year. So our plan of care for this patient was 3 times a week for 6 weeks, and we would taper it to 2 times a week for the final 2 weeks of those 6. We made this decision because the symptom sends were pretty low and they were stable. So we felt like if we could just get in there and do more work quicker, then we would probably be able to get him out the door quicker as well. And also the nature of the patient, which we talked about earlier, he was someone that just wanted to be here. He wanted to do the work. He wanted to take the work home with them. So he was motivated enough for us to feel like he could be here for 3 times a week for 4 weeks, just taper him off as we begin to get him into a more functional context. So our first 3 treatments, since our evaluation was divided into upper extremity and cervical, we continued to make assessments. What we found was gross hypomobility about the C-spine and upper T-spine joint segments. And his active range of motion at the C-spine was unchanged with passively supported arms, so that pushes us more towards joint. And then we did a deep neck flexor cervical liftoff test, which he got 5 seconds on, and really you want 30 seconds. So that's not too good. What we did was manually initially continue cervical traction to decrease those symptoms. And then we did mid-grade moves at the C-spine, mid to high-grade moves at the T-spine. And then our treatment focus was mostly manual and mobility-based, or neuromuscular rehab and mobility-based rather. So we did supine shin tucks, T-spine foam roll extensions, and we initiated prone scapular Ys and Ts without the use of upper extremities since he deferred that. And that was more of a clinical judgment initially, since we weren't able to technically measure it in the initial evaluation. Treatments 4 to 6, we continued doing assessments. We found that his right first rib was hypomobile and elevated relative to his left, so we included that in our manual treatment. The other part of our manual focus, I had taken a MedBridge course by Jack Stagg, who suggested placing the upper extremity into a provoked position or just before the point of provocation, and then doing lateral C-spine glides. And then he had reported, and so this upper limb tension provoked position became our asterisk sign, where we were able to test and retest, how are we doing distally based on some proximal manual treatment. So with our treatment, he had reported that he has been recreating every single clinic activity at home, and he has been overdosing himself that he just self-initiated. And he's also initiated a cervical collar while he slept because he wanted to recreate traction. I said, does it feel good? He said, yeah. I said, okay. So that's where we went with that. So treatments 8 to 9. Oh, and then one thing before was we had initiated the upper extremities with his prone Ys and Ts. I would have wanted to formally test the strength at this point, now that it's indicated, but we didn't. And so then we began to include the cervical proprioception laser. So the last few treatments were 8 to 9. At this point, he was beginning to suggest self-discharge. He was feeling very little symptoms throughout his daily life. So we wanted to make sure that we could get him into the most functional context that we could before we set him out the door. So what we did was we progressed the point of provocation with our manual lateral glides. We initiated manual median nerve gliding. And with our treatments, he sits on a ball at work, we sat him on a ball in the clinic, and we progressed his usual activities. So for discharge, his functional changes, he no longer wakes at night. He can work 6 to 7 hours before mild paresthesias are experienced. He still has mild anterior shoulder symptoms with the gun barrel pressing while he hunts, but he has no symptoms with upper extremity use. His outcome measure does increase 7 points to 80 out of 80. And our concordance sign, the upper limb tension test, becomes equal both sides. And he no longer has symptom reproduction with resisted humeral internal or external rotation or cervical extension. So things that I missed, I would have wanted to be more comprehensive in my initial exam. things like concurrent pathologies for rotator cuff, more comprehensive neurologic exams. I would have wanted to formally test when it was appropriate, his low trap and mid trap. And I probably should have given him the PSFS, like in that study, than the UEFI, since he had reached his ceiling already. As a clinical pearl, what I want people to take away from this is don't get too caught up in the symptoms. Just keep searching until you can actually reproduce the patient's familiar pain. And that'll also go a long way with creating buy-in. The second that I was able to recreate his pain rather than just treat an area that he experienced pain, he was motivated to come 3 times a week for 4 weeks. He was motivated to do all of his exercises, and he was motivated to self-initiate a cervical college. So those are my references. Questions?
So, going back to your severity and irritability, what were the reasons why you listed those as well?
So he objectively listed it between 4 and 6, and when I discussed it with him further, and sort of gave him like 0 out of 10 means this, 10 out of 10 means this, he ranked himself way lower.
Gotcha.
So that was just by his report to me.
And what else can you use to help kind of guide severity? Any other information that you can use to help guide where that should go? Besides MPRs?
Like how much it limits his life.
Yeah. So was he able to just kind of push through and do his workday, or was he kind
of? He said that he would feel it at 2.5 hours, and it would kind of bug him, but he would be fine.
He didn't have to stop.
Yeah.
And then irritability-wise, why'd you put low?
So I was asking him like, what kind of things bug you? And since it took him 2.5 hours, for instance, to begin to experience those symptoms, that's why I listed it as low.
And what else can you use for that too? So aggravation and
provocation.
Well, provocation, but what else can you use? As another sign to say it's high or low.
Yeah.
So if you also consider persistence, right? So it comes on after 2.5 hours, but I stand up and it goes away. So if it goes away quickly, then you would rank it lower on the irritability scale. It takes a long time or a lot of things to ease that pain, then that might be irritable. Not saying that's wrong, it's being holding. Pumping into reflexes.
So that is part of my missing components. I should have done more with the neurologic exam, especially if I was beginning to consider more proximal involvement. That would have been a really good test retest.
Good. How old was he?
58.
Okay. Jack Stagg is awesome. If you ever see his name for anything, take it. Just a fantastic guy. And he's wicked smart. Did you use your asterisk sign consistently?
Yeah. Okay. So we began, it was a little tough because we began in the middle, like 4 through 7 or whatever.
Yeah.
And each time that we did it, we remeasured it, but once he was out, he was out.
And I think one of the traps that we can fall on is over testing. So if you don't think you need to test rotator cuff, don't test it. Because if you get a false positive and you didn't test it, which I think is fine, if you get a false positive there, you might end up going down this whole other route that you don't need to go down. So I think you tested the things appropriately, based upon what was in front of you, and didn't let the diagnosis, kind of give you television and just kind of respond to some of the data. So great job.